I have the pleasure of introducing Dr. Edward Nunes, also goes by the first name Ned. I've had the pleasure of working with him in committees and by extension prior NIDA-related funded research. Dr. Nunes is a professor of psychiatry at Columbia University and does his work at the New York State Psychiatric Institute. He is the head of, I'm pretty sure is the largest node, if you will, of medications-related research in the United States that does extraordinary work, predominantly on the East Coast. He is a world-class expert on all issues that we are interested in discussing with him, like about our buprenorphine work and what about, naltrexone in a way that can be actually effective. And of course, like so many top academics, he's published more than 200 papers, et cetera, et cetera. But he's an extraordinary teacher. This I also know. He's always getting these awards from the Columbia system on teaching fellows and residents, et cetera. The point is, though, I know he's incredibly effective, and I was so happy when he agreed to come, and here he is.
Great pleasure and really an honor to be here. Jeff, thank you for inviting me, and thank you to the organizers. I want to talk today about treatment for opiate use disorder, opiate dependence, opiate addiction. Now we call it opiate use disorder, and to focus on the medications, but how do you combine the medications with a behavioral intervention to really make the treatment work? How do you talk to the patients? What do you talk to the patients about? And in terms of goals, the title really captures it. Non-adherence to medication, relapse, and also how to try to prevent overdose, which is a huge issue in opiate use disorder. These are the funding and disclosures or conflicts. I have received medications for different studies from both Alkermes and Reckitt, which are the manufacturers of injection naltrexone and Suboxone, respectively, and have done work with a company that has a computer-delivered behavioral intervention, health sim, and I've done some unpaid consulting to Alkermes and some paid consulting to Purdue Pharma. So, Jeff, I have a few of those. But they came very late in my career, so it's not too late. So I'm going to talk a little bit about opiate use disorder and how I think about it, conceptualize it, and then talk about the treatments, improving adherence and predicting dropout, and predicting overdose risk. And in the meantime, I will talk because this is mostly talk. The bottom line with opiate use disorder is that we have three medications that are highly effective if the patients will take them: methadone maintenance, buprenorphine maintenance, and treatment with injection naltrexone. There's also oral naltrexone, but the injection works better. And they work very well in terms of getting patients abstinent, and they also protect against death from overdose. But we have to do a better job of learning how to keep patients on the treatments and also begin to learn to predict who needs to stay on the medication, who is ready to go off of the medication. So just a couple of things about opiate use disorder and how I think about it. There's prescription opiate use, which is often how the addiction starts. A patient has a painful injury and gets exposed to opiates and then becomes addicted from there because that person has the inborn or acquired vulnerability to the addiction. Part of what's going on now is that there are these super potent opioids that are synthetic, fentanyl and carfentanil, which in the United States are being mixed with heroin and sold on the street. And I don't know if you're seeing that here, but it is extremely dangerous because it increases the risk for overdose tremendously due to the high potency. It's a chronic relapsing disorder. Again, it often begins with treatment of pain, and then the individual is vulnerable to opiates. Most people don't really like how opiates make them feel, and so after the pain is over, they're happy to get rid of the opiates. It's the minority of the population that is vulnerable to the reinforcing effects of opiates and therefore vulnerable to becoming addicted. And that's something that's probably just an inborn difference in pharmacologic response to the drug. There's other risk factors, but that's certainly one of them. And one of the things that's really striking and that I always try to convey to audiences is that this is a disorder with a very high mortality rate in regard to mental health disorders. The mortality rate is at least 1% per year, which means that if you take 120-year-olds with this disorder, 10 will be dead by the age of 30 unless they're treated. And that's a remarkable, and if you treat these patients, you will eventually have patients die. I mean, it's part of it. It's very, very dangerous. And the reason for death is drug overdose due to respiratory arrest, which opiates cause quite readily, and that's the issue. There's a lot of co-occurring psychiatric disorders. I got started working with patients with opiate use disorder by doing some studies on treatment of depression and opiate use disorders. Post-traumatic stress disorder, attention deficit disorder is quite common, and kind of externalizing psychopathology features, impulsivity, irritability. Dr. Stein was talking about some of these behavioral traits earlier. And there's a lot of co-occurring medical illness, HIV, hepatitis C, and also, of course, pain, painful orthopedic conditions, chronic pain. Wait a minute. There we go. Just to illustrate the high mortality rate in this population, this is an epidemiologic study that was done by Hing Hasur at UCLA in the United States. Starting in the 1960s, followed a large cohort of heroin addicts from their 20s for 30 to 40 years. And the vertical axis is the proportion of the sample, and the horizontal axis is the years. And what it shows is that by 40 years out, 50% of the population is either dead or missing. So it's an extraordinary, and a lot of these are drug overdoses, although not all of them. And then there's a small proportion, about 20%, that's abstinent. And there's a little sliver in here that's on methadone maintenance treatment, and that's remarkably abstinent. Here's a very deadly illness where there are effective treatments, and yet relatively few members of the population are on treatment. This is what we hope to make better over time with the development of more enlightened interventions. Some colleagues of mine, Adam Bazaga and Robin Williams, have written this commentary basically drawing a parallel between the opioid epidemic and the HIV epidemic that occurred in the United States in the 80s and the 90s. HIV had high mortality, a lot of stigma. Effective treatments began to emerge, but the challenge was to get those effective treatments implemented in practice in an effective way. And it's the same thing with opiate use disorder. High mortality, effective treatments, but a lot of challenges to getting those treatments implemented effectively. Opiate overdose I've talked about. And just one point to highlight, the highest risk of overdose is after release from jail or release from a detoxification or residential inpatient treatment center where the patient's been detoxified and taken off of opiates, because opiates produce tolerance. Patients who are taking opiates chronically, the system adapts and they can take large doses of opiates without overdosing. When they go into a residential setting where they're detoxified, the tolerance is reduced, and now their sensitivity to opiates is increased, and their risk of overdose is increased. And this has been clearly shown in large epidemiologic studies, both after release from jail and after release from short-term residential treatment programs. There is a spike in the risk of overdose death. And this is something that's begun to convince some of the residential treatment programs in the United States to begin discharging their patients on medication rather than simply detoxifying and discharging them off of medication, because the medication can protect against overdose. Naloxone for prevention of opioid overdose was talked about previously, and I won't go into it in detail, but this is a terrific public health initiative to distribute naloxone kits to family members, to patients, to first responders, police, fire, medical personnel, so that if they witness someone overdosing, the person's fallen out and started to turn blue and they're dying, if they can get a dose of naloxone, which is an antagonist, it will reverse the overdose and save that person's life. And there's a big effort in the United States now to distribute these naloxone kits very widely. So let me talk now about the treatments, and I'll talk about the medication treatments, and then about efforts to improve adherence and to predict dropout and relapse and prognosis. And I'll focus a certain amount on predictors, because this is supposed to be talking about behavioral intervention, but my view is that the behavioral intervention with a patient begins as soon as you start to talk to the patient. And as you're first talking to the patient, you're getting a history and trying to understand what their unique characteristics are and what their risk factors are in terms of how they'll respond to treatment, and try to start thinking about patient treatment matching. So methadone maintenance, it's a full mu-opioid agonist. It's quite potent. It has slow absorption and a very long half-life. And those are the features of a good substitution, agonist substitution therapy, is that it's a version of the drug that has slow absorption, so it does not cause very much euphoria, and it has a long half-life, so it's slowly eliminated and doesn't produce a lot of acute withdrawal. You get withdrawal eventually, but it's less acute. When it's titrated to an effective dose, which is really at least 80 milligrams a day for most patients, you get 70% or more of patients retained for 6 months in treatment, and at least 50% of those will be completely abstinent. So it's really quite remarkable. When I started working in methadone maintenance, there was no education in the United States about addiction. I was a psychiatrist. I had been taught about depression, and I was struck by how powerful this treatment is, that you can have a heroin addict who's completely disorganized, life is in chaos, and within 3 weeks they're abstinent and they're back at work, having gone on methadone. It's really a remarkably powerful treatment. In fact, one of the first clinical trials of methadone that was done in Scandinavia, I think in the 50s or 60s, Herb Kleber always shows the slides, the primary outcome measure was survival. And they actually showed that methadone reduced the risk of death. It has limitations. It has a lot of opioid side effects. In the United States anyway, it's restricted to specially licensed clinics. They're not very widely available. And there's a reason for that, because it can be diverted into the black market fairly easily. And so there's a lot of restrictions around its prescription. In the United States, there's a lot of stigma that's become attached to it. Buprenorphine maintenance. So buprenorphine is a high-affinity partial agonist. So it has less opioid-like effects because it's a partial agonist, but it binds the receptors very tightly, so it blocks the effects of other opiates. It's safer because it's a partial agonist. By itself, it produces relatively little respiratory depression. To use it effectively, there is a dose range. Many patients will respond to 8 milligrams, but many need to go up to 24 or even 32 milligrams to get a good response. So adequate dose is very important to the effectiveness of the treatment. Some patients will do well on 8 milligrams, but if the patient's not becoming abstinent on 8 milligrams, most people would say you should raise the dose up to 16, 24, even 32 milligrams to try to get it to work. Limitations of this: adherence. It's a daily sublingual pill or film strip that's put under the tongue, and adherence is a limitation. The adherence is less favorable than on methadone, and most studies show at least a 50% dropout rate by 6 months. My clinical impression of why that's happening is that it's easy to stop this medication. There's not a lot of withdrawal on stopping it, at least initially. And so it's easy for patients to kind of forget about it and walk away from it, and that's often what happens. Or it becomes part of a relapse process where the patient starts to think about drugs and gives up taking the medication as part of relapse process. So adherence is a limitation. The adherence is not as good as the adherence on methadone. So just a little bit about the evidence behind these. There's a Cochrane meta-analysis with Maddock as the first author. Maddock has updated these meta-analyses over the years. The most recent one is 2014. 31 randomized clinical trials, a lot of randomized clinical trials, over 4,000 patients. And these are low dose versus high dose, buprenorphine versus methadone, comparative trials. And the conclusions are buprenorphine improves adherence or retention in treatment, even at low doses, although higher doses are required to improve abstinence. And there's some evidence that methadone is more effective overall, a little better at getting adherence and at least adherence at least on methadone. This is one of the largest studies ever done. It was done in the NIDA-funded clinical trials network. Over 1,000 opioid-dependent patients were randomized to either methadone or buprenorphine. And this is the retention in treatment over 6 months. So the vertical axis is the proportion of patients retained for 6 months, and the horizontal axis is days in treatment out to 168 days. And you can see the methadone maintenance curve is pretty flat. You've got over 70% of patients are retained in treatment, even out at 6 months. Not all of them are abstinent, but they are retained and engaged in treatment. Buprenorphine, there's more dropout. And by the end of the study, it's down to about 40% retained at 6 months. Most of these buprenorphine patients that are retained are abstinent by the time you get out to 6 months. Ying Hasur did a long-term follow-up on that trial that I just showed you. So she and her team were able to locate 90% of this sample of over 1,000 patients at a 4-year follow-up point, and they measured their outcome. And among the analyses, they looked and were able to discern 4 different trajectories of treatment outcome. What happens to these patients over the long term? And there were 4 different patterns. There was a pattern, the low-use group. Vertical axis is days using opiates, and the horizontal axis is months after enrollment in the trial. So here we are going out from enrollment in the trial out to 4.5 years. So one group stops using or decreases their opiate use dramatically right away and stays at low use over time. That's the low use group. That's the biggest group, 42%. So pretty good prognosis for these patients that entered treatment way back here. One group just does badly the whole time, high use group. They go in treatment here. Maybe they use a little less while they're in treatment, but they just go back to using opiates almost every day. Then there are a couple of other groups that are kind of in between. There's a group that starts out looking good and then gets worse over time, the increasing use group. And then there's a group that starts out looking bad, but then gets better over time. One of the things that this tells me as a clinician is that if I look at how the patient's doing in the first month or two, it's a window into the prognosis. And if the patient isn't doing well in the first couple of months, I should do something different. I'm not sure what, but I should intervene with something new to try to help the patient. Because these patients, a lot of them are in trouble. These patients are doing better, and maybe they don't need as much attention, or at the least, you should just keep doing what you're doing. So she also looked at patient-level predictors of long-term outcome. So the strongest predictor of who was going to be a patient that was using very little opiates in the long term was being on medication treatment with either methadone or buprenorphine. So being in medication treatment was really the strongest predictor. And that's really a main message from my talk, is that all the evidence from these studies suggests that stopping treatment is a strong risk factor for relapse. Not everybody relapses, but many people do. And we're not very good yet at predicting who can stop the medication and continue to do well, and who can stop the medication and relapse. But we do know that when the medication is stopped, there's a high risk of relapse overall. There were a bunch of other predictors. Some of them were consistent with clinical severity, which kind of makes sense. Patients using cocaine, patients using heroin intravenously as opposed to taking it by mouth or taking prescription opioids. Psychiatric symptoms, greater severity. So these were variables related to severity. So a more severe patient is more likely to be doing badly over the follow-up. Younger age. The younger patients are harder to treat, at least in the United States. So, so there's more we need to learn about the young patients. And West Coast. So oddly enough, this study was done on the West Coast of the United States and the East Coast, and programs all in between. Programs on the West Coast, the patient had worse outcome than programs on the East Coast. Nobody knows why, but I think it speaks to geographic and cultural factors, perhaps, that are influencing either who the patients are or what the treatment programs are doing, and so forth. This is another of the studies of treatment of prescription opioid dependence by Roger Weiss and his colleagues. It was done in the CTN. I won't dwell on it other than to say that the findings were very similar. Stopping buprenorphine was associated with a high risk of relapse. So the predictors of long-term abstinence, because they did a long-term follow-up, was being on agonist treatment with either methadone or buprenorphine, and a severity variable, never used heroin. Patients that had only ever used prescription opiates are probably less severely ill and were more likely to be doing well over the long term. So in summary, both these medications are effective. There's a lot of dropout and some predictors of dropout, but the long-term studies are telling us keep the patients on the medication when in doubt, because that's the best way of protecting against relapse. What about behavioral treatments? There's been some research on adding behavioral treatments in a strategic way to methadone or buprenorphine to try to improve adherence. And Kathy Carroll and Roger Weiss recently published a review of this in the American Journal of Psychiatry in 2016. They found 8 randomized trials that tested different behavioral interventions. And they found that so far the evidence supporting added behavioral interventions in general was weak. There wasn't a clear signal yet for what kind of behavioral intervention would improve adherence and outcome on buprenorphine. However, contingency management, there were several studies of contingency management. This is where you give patient rewards contingent on adherence or abstinence, and this was effective. So if you had a way of rewarding the patient for staying in treatment, this was effective in improving adherence and outcome to buprenorphine. Let me talk for just a few minutes about naltrexone. Naltrexone is an antagonist, so in some ways it's a perfect treatment. It blocks the opiate system, shuts the opioid system off, and has no agonist effects of its own. There's some downsides to it, including that the patient has to be detoxified to get onto it. So there's an induction hurdle. In some ways, it's a perfect treatment. It was originally for many years available only as a pill, and the problem was that adherence was very poor. It was too easy for the patients to stop taking the medication, and then they would relapse. So along came long-acting injection naltrexone, which was an idea that was long in the making. It was encouraged by the National Institute of Drug Abuse. And this long-acting injection, these are injections. They're based on a technology where the drug is formulated into plastic microspheres mixed into a suspension and injected. It's a big, fat 4 cc nasty injection. So the only muscle in the body that's big enough to take it is the buttocks. You have to give it in the buttocks. It's painful, but not, the painful injection effects wear off after a few days. It clearly improves adherence and outcomes. More studies are needed in terms of how to improve the retention behind what we've got so far. And let me just focus on this slide, and then I'll wrap up. So this is data, a secondary analysis from one of the 2 large-scale effectiveness trials of injection naltrexone that have been done so far. This is a study that our group participated in. It was a 5-site study in the United States of about 300 patients who were involved in the criminal justice system in one way or another. They had been in legal trouble one way or the other. And they were randomly assigned to either injection naltrexone which is the blue line, or treatment as usual, which was typically, at the time the study was started, counseling treatment without any medication. And these are survival curves. So the vertical axis is the proportion of patients who have not relapsed. All the patients were abstinent when they started the study. Relapse was defined as a return to regular opiate use. So the vertical axis is the proportion of patients who are still not relapsed, still doing well. So these are relapse curves. And this is time. So this was a 6-month study. So this is initial study entry out to 25 weeks. And what was particularly interesting to me about this study, the study took place in 3 different settings where treatment was initiated. Some patients started the study on short-term inpatient units, 7 to 28 or 30-day short-term residential treatment programs. Some patients started the study on long-term inpatient units. And in the United States, we have some units that can hospitalize patients for 3 to 6 months in residential programs. The majority of the sample actually started as outpatients. So these were patients who had already been abstinent from opiates and living in the community for a period of time. You would think they would continue to do very well. They've already gotten themselves abstinent somehow, and they've been living in the community. They haven't relapsed. So outpatients, long-term inpatients, short-term inpatients. And what you see, and what I was looking for and what we observed, was this very rapid relapse rate among the short-term inpatients who were treated with treatment as usual without a medication. Over 60%, over 70% actually have relapsed within the first month when discharged from a short-term inpatient unit without a medication treatment. And this is an important finding. I think it says with short-term inpatient treatment, which is very valuable, you get the patient out of their home environment that's very toxic, and you get them detoxified from opiates, you protect them from the environment. But if you just discharge them back to the environment, the rate of relapse is very high. On naltrexone, almost no relapse in the first month. And this 1-month point is when the first shot starts to wear off, okay? So the shot lasts for a month. The shot starts to wear off, and all of a sudden there's this drop-off. There's this relapse phenomenon that occurs. And that is due to the fact that a bunch of patients don't come back for their second shot, okay? I think it was over 80% of the relapses happened after the person had taken their last shot and discontinued taking the medication. Overall, over the 6 months, the naltrexone does better than the treatment as usual, but there's also a lot of relapse on the naltrexone. The reason there's relapse on the naltrexone is that the patients have stopped taking the medication. While they're taking the medication, there's almost no opiate use. The urines are almost entirely negative. So it shows the challenge of creating interventions that will help patients to stay on the medication, so there'll be a survival curve that looks like this instead of looking like that. The other thing that I find interesting is this 20%. 20% of the sample, even of the short-term inpatients, don't relapse over 6 months. They don't need the medication. For these other groups, the long-term inpatient and outpatient, this group is a little bigger. 30, 40% of the patients survive over 6 months without any relapse, even without medication. So who are these patients with a better prognosis? And how can we figure out who they are so we can counsel them and say, you know, I think you're okay. You probably could do okay without medication, whereas there are other patients where you can say, you've got to stay on naltrexone because you're in this group that's going to relapse if you don't stay on medication. So this is the challenge. And so far, in terms of looking at clinical predictors of who's going to relapse and who isn't, and who is going to benefit from the medication, with clinical predictors, we have not found very much to help us, other than perhaps a general idea of severity, but it predicts very weakly. And so I was interested in Dr. Stein's talk about the MRI predictors and whether those kinds of brain measurements that don't map obviously onto things like clinical severity might actually ultimately, with some research, help us to essentially do patient treatment matching. Can we tell patients which group they're in, the good prognosis group, the bad prognosis group, the group that needs medication, and the group that doesn't? Just a quick note that there are also long-acting implants and injections of buprenorphine that are coming. And there's an implant that's already approved. It doesn't provide very high blood levels, so it's probably not as useful for acute treatment. There's an injection that's coming that provides blood levels that are as good or better than the sublingual. And it's a very nice injection. It's a little 1 cc injection, and you can give it in the arm or the abdomen. It's subcutaneous. It's very easy to administer. And so this is hopefully going to get improved and marketed fairly soon, and could be a substantial advance, because I think, as with naltrexone, this will help with adherence to buprenorphine. It will help prevent the patient just randomly walking away from the treatment. So just conclusions, we have 3 very effective medications. The major barrier to their effectiveness is adherence, and we need to do a better job of predicting who's going to have trouble with adherence. And of course, the overriding concern that relapse and stopping treatment is associated with overdose and death from overdose. And future directions, how can we improve adherence? How can we make naltrexone initiation easier? How to improve prediction of prognosis and who needs to stay on medication and who doesn't. And another issue is how to predict who's at risk for overdose. I'm convinced that patients vary quite a bit in their inherent risk of dying from a drug overdose. And if we knew that, it would help us counsel patients, because we could say to a patient, if we had such predictors, you are somebody who's at high risk to die from this, and so you really need to take it seriously and adhere to treatment. So I'll stop there. I'm sorry, I've run over, but tried to speed it up. I guess time for questions.
Yes. Do we have any questions?
And I'm certainly happy to talk to people after the
Yes.
session as well.
Did you raise your hand? No? You please.
Can you hear me?
We're starting with Rehan. Okay,
Yep.
very good.
Thank you very much, Dr. Nunes. This is a fascinating talk. I had a question. You said that in the first month when somebody doesn't do well, something differently needs to be done, but you're not sure what. Empirically, can you tell us what?
Well, I would think about contingency management. I would think about getting the family more involved. So there's some evidence with treatment with oral naltrexone and opiate use disorder that if you involve the family just in a very simple way to have them help the patient take the medication every day, that's helpful. So contingency management, involve the family more. Perhaps medications might have a role, antidepressant medications if the patient's depressed, medication for attention deficit disorder if the patient has attention deficit disorder. So there are a number of things like that I could think of. So more intensive behavioral intervention. Certainly increase the dose if you're working with methadone or buprenorphine. So there are a number of hypotheses of what you could do. Not a lot of evidence yet. And of course, you've got to grab the patient quickly before they disappear, because they disappear and then you have to hunt them down. Although in some of our studies, we've had a tracker as part of the team. And the tracker is someone who goes out into the community and finds people. It's like a private investigator. They have all the data on the patient. They have the driver's license number and the social security number and the names of the friends, and they go out and find people. And they track them down. And the consent form says, we will come and find you if you disappear. So they know this is coming. And people are usually very grateful to be found. They say, gee, I really appreciate that you came and found me. Everybody worries, oh, this is invasive, you shouldn't do it, you're invading their privacy. But the typical response is, gee, I really appreciate that you came and tried to find me. So that's another dimension. Sometimes it's called a patient navigator. But this is a little different. It's a tracker, someone who is going to find the person and make contact, no matter what. The epidemiologists have been doing that for years in their studies. Dr. Hing Sur found 90% of those patients that entered the CTN study 4 years later. So you can do it if you track people.
Please.
Naltrexone in tablet form and injection form in relation to alcohol misuse. How is it?
So naltrexone is also effective treatment for alcohol, and that's a good point. It's not as strong a treatment for alcohol as it is for opiates. Virtually 100% of opiate-dependent patients will get complete blockade of the opiate system with naltrexone. We occasionally see patients who don't get a complete blockade. There's a tiny little subgroup maybe, but it's across the board with opiate dependence. With alcohol use disorder, the so-called number needed to treat is something like 4 or 5, which means that 1 out of 4 to 5 patients with alcohol use disorder respond to naltrexone. When they respond, it's very good, because what they describe is that they no longer are interested in alcohol, and it's very striking. They'll go to dinner with their friends, and you know, in our country, people drink wine with dinner, and it used to be they would get drunk and make a fool of themselves, and now someone pours them a glass of wine, and they have a few sips, and they say, I don't want it anymore. It's very helpful for that fraction, but it's only a fraction of the patients. But I would say that for patients who are hospitalized for a serious alcohol use disorder, it's worth trying, because it will work for some of the patients. It's a lot like antidepressants. You have a patient with depression. You pick an antidepressant medication, but you know that that medication isn't 100%. It's only going to work for a fraction of the patients. But for those it works well for, it's terrific. And you can tell within about 3 or 4 weeks if it's going to work for the alcoholism. If it's not working, you can stop it and maybe try disulfiram, for example, you know, which works in a different way. But I would very much encourage, and with alcohol use disorder, there isn't the same concern about stopping the treatment and having an overdose. And so it's okay if the patient with alcohol use disorder takes the pills intermittently and not all the time. In fact, naltrexone has been studied as an as-needed treatment for alcohol use disorder, where the patient's instructed, if you think you might drink tonight, then take one. And that's actually been found to be helpful. It's interesting that it can, if the patient says, yeah, I'm going to a dinner with friends and I'm going to be tempted to drink at that dinner, and then they just take it at those particular times. So I would encourage using it, understanding that only a fraction of the patients is going to respond.
Do patients who are using the naltrexone implant do better compared to for patients who are using injection or oral? Because theoretically, it seems that they will avoid the drop that happened every month.
So the implants are available in some countries, but not as well developed yet. So the best clinical trials are from the implant that's been available in Russia. It was developed in Russia. And it seems to last for 2 or 3 months. They're little pellets, and they're implanted under the skin in the abdomen. The downside is that it looks like something like 10% of the population does not develop any blood levels. They think it's because the implant gets walled off with scar tissue, so the drug can't get into the system anymore. And so it appears that there's a kind of failure rate. Whereas with the injection, it seems quite reliable that you'll get blood levels. There's also an implant that's being developed in Australia that supposedly has a 6-month duration of effect, although there isn't as much really formal clinical trial data with it. And I think the same problem of some patients not having any blood levels is going to obtain. So I think it'll probably be very useful treatment in the end, but with the understanding that it may fail in some patients, and you might need to change to a plan B. To my knowledge, there have not yet been any comparative trials of implant versus injection. There have absolutely been comparative trials of implant versus oral, which show that the implant is far superior to oral naltrexone in terms of opiate use disorder retaining patients in treatment. keeping patients in abstinence. So I think they're coming, and I think they'll be useful, understanding that they may fail for a fraction of the patients.
Okay, I think we're good actually on time, right? Where's Diana not here? Oh, good. So we should move. Okay. Thank you.